Tuberculosis here in Kenya, as the world is marking Tuberculosis Day this weekend that began yesterday. Allow me to introduce my very well-enabled panel. Sitting closer to me is Dr. Stephen Muleshi. He is with Maryland University, and next to him is Stevie Otieno. He's the TB advocate, and next to Steve is Dr. Kelly Habala, a TB prevention advisor. Gentlemen, thank you so much for your time this morning. Now, I was reading quite a number of statistics. Well, they were quite a bit scary, but before we can jump into that, I'll start with you, Dr. Stephen. What exactly is TB, and what are the symptoms? How can one know?
Thank you very much. Let me correct. First, I'm from the Ministry of Health, National TB Program, here in Kenya.
Right.
Yeah, so TB is an infectious disease. It's a bacteria that is known over the last 100 years to infect human beings. But we also have other forms of TB that can infect animals, what we call bovine TB. But for today, we'll focus more on the human TB. And the signs and symptoms of TB are basically, usually someone will present with a cough. Initially, we used to say cough of duration of more than 2 weeks. But now it's a cough of any duration will be a very important symptom to a clinician. There may be symptoms of fever, having hotness of the body, sweating at night, losing of appetite, but also loss of weight. So those are the major symptoms when someone is infected with TB. Yeah.
What are some of the myths that are wrong when it comes to TB?
Okay, over the years, we've had many myths as far as TB is concerned, but what we know for sure is that TB is airborne, transmitted airborne. If someone coughs and there are people around that person, they are likely to get infected because of the droplets, the cough or droplets that go to the air and then they're inhaled by the people around. But if you share with someone a bed, you're also likely to get TB. We're talking of close contacts in a house which is poorly ventilated. And it depends on the duration also of exposure to a person who's infected. So if we share a cup, for example, if this person is not coughing and releasing the bacteria into the air, might not be really able to get the disease.
Kelly, as an advocate for TB, I'm sure you've been on the ground and you've got to interact with a number of Kenyans. What are some of the myths that you have heard as well? Yeah.
Also, just to correct my title, I'm not a medical doctor. I've studied clinical medicine and I'm now specializing in public health and epidemiology. Yeah. And of course, I work for University of Maryland. Yeah, some of the myths, of course, we've heard about when we interact with communities out there is one, of course, they believe that TB is disease of the poor, while in reality, we can see that TB affects all socioeconomic groups. You know, in some families, also they believe that having TB is a curse. Yeah, and that there could be something wrong because we've seen patients who, when they have TB, they waste away. Many years back, it used to be called a consuming disease, because you would then lose a lot of weight. So they kind of want to associate that, as my colleague has said, as probably a curse.
You've mentioned that one of the myths is that TB is only for the low-income community. But isn't that not the case, given the fact that TB thrives within healthy conditions and clean places, etc.? Because one of the stories that we did run earlier on, actually, is that TB cases within our prisons has gone up very drastically, given the conditions within that environment.
Yeah, actually, the right message is TB affects all socioeconomic groups, but of course, being poor is a risk factor. Right. You know, because most of people who are in low socioeconomic situations, you know, they tend to overcrowd because of resource issues. And this is why we are receiving high numbers. But it doesn't mean that among the rich, we don't have numbers. We also have numbers as much as they are isolated. Yeah.
All right. Steve, let me engage you a little bit. First of all, you're wearing a helmet in studio. Tell me a little bit about that.
This is a label called hashtag 20TB, especially in Kenya and across the world. Yeah.
All right. And how did you find yourself lending your voice to TB?
TB, I come a TB advocate after losing both of my parents.
To the disease?
Yeah.
Uh-huh.
Yeah.
When was that?
My father left me when I was 2 years, and my mom also left me at the moment I turned 3. Yeah, so you can just imagine the life there at that young age. Yeah, so I passed a very hard life. Yeah, so
and that's why it's important for you to be an advocate.
Yeah.
As a young person as well.
Yeah.
All right. What does being an advocate for TB, and I love the hashtag end TB, what does being an advocate mean? Does that mean that you get to talk to young people?
My story is different. I am a TB advocate because I am an artist and I am using my talent to write more songs, to write more TB songs so that I can create awareness in the community. Yeah.
All right, that's how you're doing it, by creating awareness through music.
Yeah.
All right, Dr. Stephen, there's something that, some of the statistics I was looking at, 29,000, that's the number of Kenyans that were killed just last year, according to the World Health Organization. What more can you tell us about the facts and the figures within, for example, your data system, now that you do represent the Ministry of Health? Where are we as Kenya when it comes to fighting TB?
Okay, so as Kenya, I think maybe if I could just share the statistics of last year, because we've already analyzed that. We notified about 85,000 cases of TB as a country, of which about 9% were children. And that is the drug-sensitive TB as we speak. We have the form of TB which is resistant to conventional medication, which we call MDR TB. Last year, we also notified about 577 cases, and of which about 27 were also children. Yeah. So in terms of statistics, also we had what we have called a prevalence survey that was done sometimes in 2015, showing that as Kenya right now, the prevalence of the burden of TB as a whole is about 426 cases per 100,000 population, which is quite still a high number comparing to the targets, NTB targets that the UN is advocating for. But also we are seeing that we are missing a lot of cases. We still have a lot of cases in the community. About 40% of the cases are being missed. And this is where the focus now is going to be in the next few years, looking for those cases.
It's good to hear that.
Yeah.
What are some of those loopholes, Dr. that are sort of, that we can tie to make sure that those numbers go down? What are some of those loopholes?
First of all is to sensitize the community. The community needs to know that TB exists and it's dangerous and it can infect anybody. I think the myth that it only affects the low class people in the community, to some extent is true, but everybody can be affected by TB. So looking at the community, sensitizing them so that we create advocacy and demand to visit our facilities if you develop symptoms.
How can we prevent TB? Are there things that we can do at home, even within our own home states?
Yeah, TB is easily preventable and also it's easily curable. And that is some information that also the community, the public needs to know.
Okay.
First of all is if you develop a cough, first a cough of inhalation, don't wait. Please seek medical advice, go to a facility or a clinic so that you can be tested of TB. Because we have tests that are available at the facilities, and you can easily be tested. And if you're found to have TB, you're immediately put on treatment. Because one of the key prevention measures is that person who has TB, once he's put on treatment, you cut the transmission to the society. But also cough etiquette. I mean, if you're coughing, it's advisable that you develop proper cough etiquette. Instead of spreading the bacilli in the air, you cover your mouth. either with your arm or handkerchief, but not in the bare hands. So that you also stop spreading with the community. But contacts of TB, like small children, can also be prevented from getting TB by putting on some treatment called isoniazid treatment. Because in our home, a child will get TB where there's an adult with TB. And so to prevent those ones, the children, you'll usually put them on treatment for about 6 months, while the adult is on treatment also. Yeah.
All right. Now, this year's theme with TB is Wanted, Leaders for a TB-Free World, with, of course, the World Health Organization urging leaders to join their hands when it comes to fighting this specific disease. Kelly, I want you to jump inside here, being an advisor. Do you think leaders more so here within Kenya are doing enough to fight TB?
Yeah, what I would say, yes, leaders have done a lot, but as a country, we still need to do more. It's not enough. Yeah. One of the biggest things that affects, of course, TB program is funding.
Funding, yes.
Yeah, so of course we are encouraging, governments and of course other implementing partners to add in, extra resources for TB screening. When you realize, like the current methods we are using for screening, they are quite basic. We simplified, and is also to some extent because of resource issue, because we are mainly doing symptomatic screening. But if you look at the TB survey that was done 2015, 2016, it's already indicating that that screening still missed some cases. While a chest X-ray, for example, through imaging, were able to identify some of the cases that even with symptomatic screening, they were missed out. X-rays, quite expensive. It's not accessible to majority of Kenyans.
Right.
And most regions are also not able to put up a chest X-ray machine. Yeah. If we look at the way the healthcare system is running, for example, now you realize, like health-seeking behavior, we are able to catch more female and children in our health facilities because we are operating from 8 o'clock up to 5 o'clock, while the TB burden is so high in male population. But
in the male population?
In the male population,
all right,
which we are not catching, because like in an urban setting, like in Nairobi, you'll find most of the male, people who, they go to industries, wake up very early at 5 a.m., for example, to go to work. They then leave at 5 o'clock. When you're closing the facility is when the guy is also leaving his workplace. So by the time he reaches home, of course, the facility is closed. On a weekend like today is Sunday, this is when most men are out there drinking together and probably having time to come for screening and checkup. Most facilities are closed. So of course, if you have to work extra hours, this means that probably facilities need to think, and government and leadership, about finding a resource to either operate extra hours. Like for the HIV program, I know some partners are already operating like over the weekends just to catch adolescents and male. Yeah, so that then they can visit facilities. We are also encouraging, private business owners, especially institutional leaders, to also allow healthcare providers to have a program where they are doing outreach so that then they can visit specific congregate setting. Like in schools, for example, sometimes the processes of healthcare workers getting into schools to get children screened is not very automatic. Sometimes you have to do lots of later sitting down and requesting for this permission, because kids also during school time, actually their business is to go to school. So they're also in school very early and they leave late. They cannot access most of the facility where you're doing screening. Yeah. So
those are the key areas that we can definitely work on as a nation and some of the leaders.
Yeah.
Steve, I can see you nodding to this. You're in agreement with this, especially you being an advocate for the disease?
Yeah. You see, TB now, what I can say, TB now in Kenya, it is the highest killer disease in Kenya, because according to the WHO, each and every day we are losing like 120 people dying of TB. So you can just calculate that number in a year. So we are losing more people And that's why we would like the government and the donors to come in to fund some of the NGO there, the TB advocates, so that we can reach in the ground. Yeah.
Go deeper and reach more people.
Yeah.
Kelly, there's something that you said that I picked on, the habits. The drinking together as well, because you find a lot, especially within rural areas, you find men seated within an area and they are all drinking from one, let me say, one pot. Yeah. So habits also plays quite a big role.
Yeah, this is what we've seen with communities. In fact, for the last 1 week, within Nairobi County, we've gone in informal settlements trying to sensitize, alcohol den owners to allow us do TB screening among this population. And actually what we realized that, again, because of anti-alcohol regulation in this country, some areas are open for the drinkers, very early in the morning, but because of this regulation, they close the door, they close the window, right, because they fear being caught up by the law enforcers. So you find lots of men in there, and also youths, actually, who are closed up in these places, drinking from morning almost till evening. No good aeration in these places.
And sadly, within young adults, the younger generations, the millennials, it could be shisha, because you do share that one strand of smoking tail. And it was banned, then the ban was removed again. So would you say that, for example, within shisha, within maybe, for example, your research and your findings are for young people, the millennials, the younger adults, that could be one of the driving causes of it?
Yeah, sure, it's a risk factor, because we see where house shisha is smoked, usually we have lots of young people together, and at times they're even sharing the straw. We've seen this. One of them or two is coughing. So it's a risky behavior for TB infection.
All right, Dr. You also agree. I'll let you just
drop I do agree. The issue of shisha also, even the environment where they take, usually you'll find maybe it's in clubs where there are a lot of people also. So the environment alone, apart from the shisha sharing, the straws, is a risk factor. But you also know smoking. Smoking and alcohol, so they're also been known to be risk factors.
The driving factors.
Yeah, driving factors too.
All right. Well, we're going to take a quick break here on Weekend Express. Of course, when we come back, we still have